You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
This is the Pain Pod.
You want to see pain? Look at these.
Welcome to the Pain Pod, the podcast for all things pain management. Hosted by the Pain Guy, Dr. Mark Garofoli. We'll be collaborating with numerous pain management experts, talking about substance usage disorders, the latest treatment modalities, and most important, focusing on the pain of our patients as leading providers of pain care. And now, here's our host, a man wanted in all 50 states, a suburban city-like mountain man,
Without the beard.
from the hills of West Virginia, and certified in weapons of mass destruction response. It's Dr. Mark Garofoli.
All right, welcome back everyone to the Pain Pod. Well, today we have actually a continuation. There's always new information, but a continuation of what I was terming opioidology. The overall, we started with the story of our opioid crisis, everything opioid overall. We navigated into even within the clinical realm of opioid selection. And we're going to kind of kick back today with something that really caught my eye. Turns out, I'm sure you know this, and you might be of the same mind. Heck, you are listening to the Pain Pod. There's other people thinking about the same things of this overall opioid story per se. You know, what we got ourselves into as a country and quite frankly, globe for that matter. But the good parts and the unfortunate parts of the overall story of, unfortunately, the loss of lives in the big picture due to drug overdoses. Still certainly paling in comparison to alcohol-related deaths and tobacco-related deaths, but that's a whole nother can of worms. But we have had some improvements in recent years when it comes to, decreasing the overall drug overdose deaths in our country. It used to be well into the six figures, and we had quite the dip. And I really want to, I don't want to underemphasize when I say a dip, because that's a lot of heartbeats saved, or at least not lost, right? There was not that long ago, we had about 111,000 drug overdose deaths each year in our country. We made it down to about 75,000 more recent days. The bigger picture, though, is the hope that it's not a momentary decrease, that it actually continues overall. Right. But, big picture, an American still dies about every 6 minutes from a drug overdose death. So this is well beyond clinicians, healthcare professionals. This is society overall. Now, in trying to put together all the information, this is where there was an article that certainly caught my eye recently. I'm pulling in some of the authors here today to talk it through a little bit more granularly. But you may recall, if you haven't listened, check it out, the first Opioidology episode of the Pain Pod. I went over what is illustrated actually on painguide.us. When you go on the tab for Pain Pod, you can see one of the charts to really look a little bit deeper and earlier as far as the numbers of what goes into, drug overdose deaths, opioid overdose deaths, prescribing of controlled substances, particularly opioids, the trends overall going back further than just, what leads us to saying all the extremes. There's a lot of blurred lines when it comes to pain, addiction, and substance utilization, of course. There's a lot of extremes out there these days and in the past, things like Opioid-Philia, Opioid-Phobia, really building upon what we talked about in Opioidology Part 1 as far as the Pain Pod episode. But I really want to jump into it today with the article. We'll have it in the show notes, of course, and certainly within the painguy.us website as well. But, titled "The Burden of Acute Pain in the United States in the Wake of the opioid crisis. That was in Frontiers in Pain Research. And we got some of the authors with us here today. So I really want to, welcome James and Jim to the microphone here. So, hey, flip a coin, gents. Who wants to go first for a little intro of yourself?
James, why don't you go ahead?
Sure. Well, thank you for that introduction, Mark. Thank you for having us here on your show to talk about this topic. My name is James Hackworth. I'm a scientist by training, actually physicist. Had the opportunity for almost the last 15 years to work in drug development, and almost all that time at least in part or wholly in pain drug development. And actually founded a company a few years ago to develop a pain drug, which is what brought Jim and I together, because that company was then acquired by our current employer, Tris Pharma. I actually have a personal connection to these topics as well. My parents grew up in Scioto County, Ohio, which is probably not familiar to many of your listeners. It's a small population county tucked along the Ohio River in southern Ohio. And it had the infamous distinction of being really one of the first places where the opioid crisis hit back in the 90s. And actually, I believe the first place that fake pain clinics started being set up, and people would come from far away to go there to get prescriptions of OxyContin or whatever. And at one point, 25 years ago or so, it was in the top 10 prescriptions of opioids in the country of any county, despite having 50,000, 75,000 people, something like that. And unfortunately, this topic that we're talking about touched my family very deeply. My grandmother's sister, 30 years ago or so, younger sister, was in a really bad auto accident and was prescribed opioids. And of course, they helped her pain, but she became addicted even after her injuries had healed, and really started a very long, probably about 15-year addiction, in which case she really wrecked her own life and wrecked relationships with family, and eventually died of an overdose. And which is obviously was devastating for the family. But then I also, because of that, got to see the other side of the coin that we're talking about. My grandmother, her sister, when she got to be elderly, was in tremendous pain all the time. She had very bad osteoarthritis all over her body, and she also had diabetic neuropathy, which, as she got to be older, caused a lot of pain in her lower legs. And she couldn't take NSAIDs for the osteoarthritis because she was on Eliquis for a separate issue, and doctors wouldn't allow it. She took pregabalin for the diabetic neuropathy, but it didn't give her much relief, and so the doctors offered her opioids. And because of what happened with her sister, she refused to take them. She was well into her 80s, but said, I don't want to get addicted. I don't want that to happen. It's like, Grandma, it's probably fine, but she wouldn't touch them. And so she really lived about the last decade of her life in really severe pain, basically around the clock. And it was really painful to see. And so kind of sort of both sides of the topic here are very personal to me.
Absolutely. And I just want to throw it out there too. Thank you for sharing that, because, a lot of times in our life conversations, whether on a podcast or all of us, all listeners too, there's a lot of touch points with this overall opioid story overall. So thank you for sharing that there. Means a lot, of course, for hearing the touch points. So.
Well, I'll pick it up from there. My name is Jim Potenziano, also a scientist by training. I've got a dual PhD. Former academic. I've been in the pharmacy industry a long time. I chose to leave my academic position and go into the pharma industry just because you could have a broader impact, quite frankly. And I've spent my whole career doing medical and development in the industry. Initially, I was engaged in pain because my training was in and around development of chemotherapeutics, and I spent a lot of time around cancer and people in cancer-related pain. So I got a good exposure from that perspective. My first job was with Johnson & Johnson, and we were as a company struggling with transdermal fentanyl. Titration was a real problem. We spent a lot of time talking to people about how to use the product. You got a very good experience with it. But it was also at the same time that the whole oxycodone evolution was occurring. And so I've been in it for a long time. I've developed a few products over the years in the pain industry, and actually joined TRIS because I had looked at the initiatives that they had and thought that this could really add some substantial value to the pain environment. So thank you very much. As with James, I appreciate, Mark, you having us on, and I look forward to the discussion.
Of course, we want the movers and shakers on here all the time, and I think we have both of you here today in that regard. So now, again, one of the things that really catches the eye, and hopefully folks can read through or at least listen through today, was this article that both of you were part of. There's other authors, of course, too, but the burden of acute pain. Particularly in the shadows of the opioid crisis overall. Now, James, the personal stories you shared certainly dive right into that, of course. But when thinking about what you guys were putting together, collaborating with other authors, there's a lot of dynamic concerns within our overall opioid crisis, the story in the big picture, in the realms of addiction, pain management, and beyond. What would you summarize the big picture takeaways for that article? Like, what would be the biggest things there to take away?
James, you want to pick up the takeaways, and then I'll go into some of the more detail underneath it?
Yeah, sure. So I'd say that one, we're doing this in the backdrop of pain is continuing to rise in the U.S. Acute pain in particular, as we get, the population gets older. Obviously, age and obesity are two of the biggest drivers of acute pain. We're seeing more and more acute pain episodes, whether that's post-surgical, post-emergency department visits. And I think as Mark, as you know very well, and I think probably most of your listeners know, there aren't a lot of therapeutic options for more severe pain, especially. And often opioids are the only thing that you can give someone to treat a lot of the more severe acute pain. And that then, of course, there's a lot of risks with opioids, which we get into in the paper and we'll get into in this discussion. But it really puts kind of clinicians and patients between a rock and a hard place, so to speak. On the one hand, there are legitimate risks of prescribing an opioid, even for short term. And the paper goes into that. And on the other hand, and I think probably something that's not as appreciated, there are significant medical long-term risks to not treating pain effectively especially when it's more towards the severe end. Pain can easily become chronic if you don't treat it when it's in that acute phase. And so, as we've been out talking to people over the last few years in connection with what we're doing, it's apparent that a lot of people have sort of one of these two problems in mind, but we didn't see a lot of balance where people were kind of thinking about these dual problem at once, that the need to treat pain as being an urgency, but also the need to find a way to not cause downsides related to prescribing opioid as an urgency. And so we decided to look at, with our other authors, decided to go and look at what all the research is that really can inform what the real risks are, rather than we're just sort of thinking in panic mode. But what are the numbers really behind the risk of prescribing opioids for short term? And also, what are the risks of, if you're saying, okay, well, that's too scary, what are the risks of not prescribing and not treating pain, or potentially leaving pain ineffectively treated?
So I think that's actually a great lead into, what did we find out and where are we today? And there's a bifurcation as you look at this. And frankly, I think if you talk to people generally who treat pain all the time, they probably don't look at it with the same eye as many do. But we have to keep our eye on the people and the needs for the product, because ultimately it gets down to what are we trying to do? We're trying to basically appropriately treat pain and make sure that we've got the right recipes to do that. So what we kind of did is we started to think about that bifurcation in terms of provider reluctance on one side versus patient reluctance or challenges on the other side. And so let me start with the provider and some of the things that we actually thought about and contemplated in this paper. I'm sorry?
Sounds good.
Okay. So, it's interesting because if you looked at the numbers in totality and you did this as a proxy of numbers of opioid scripts, you would probably think, well, is there really a problem? That if you look at the last 10 years, we're nearly cut in half with number of opioid scripts that have been written. And the bottom line is, it goes back to what I was saying. If you are sitting in the right place, and for example, if you are a pain physician and you've become very comfortable with the downsides of these things, and you are comfortable with the utility of them and where to use them, it becomes a conversation for you that's much simpler. But it's really not that simple. And as you look at this from a more holistic standpoint, and you bring the people in who more historically use these products, because as we know, a lot of people and areas of medicine have actually fallen out of use of these. And I love to give this example. My partner is a dentist, and she's been a dentist for over 20 years. And I always tell people, it's a very interesting dynamic when we talk about this, because in the last, let's call it 5 years, she is largely, and it's not just her, many of her colleagues have gone away from the use of opioids. They'll get calls. She had a couple of dental offices. She would get calls on the weekends for emergencies frequently, whether it be an abscess or broken tooth or whatever, but people in substantial pain. And what she ended up doing many times was going to the more rudimentary, let's get you on an antibiotic and get you started and get you scheduled as soon as possible, simply because it became too big a risk in that area to be writing opioids out, which is historically something that profession probably would have done. And if you step back and ask, well, is this the only area of medicine? I think the answer becomes obviously no. As we researched it, we talked to more people. There's certainly more generalized areas of medicine, primary care. We've seen dramatic decreases in the amount of opioid that's been used, whether that's acute or chronic pain. And even when you point to the more acute end of this and look at it from the side of emergency medicine, there has been a substantial decrease in the use. And frankly, we're out talking with some of the developmental initiatives that we're doing with emergency medicine departments that frankly have kind of gone away from this in their entirety. So if that from a provider standpoint will show you that there is a disconnection between the way things used to be and the ease of use of some of these products and where we are today. And then if you just simply flip over to the patient, there's a different story, but not less complex. And it goes back to some of the things that James was talking about. The people are not as knowledgeable about what everything is in the opioid environment. They're reacting to what's being said in the government. You can't help but hear things, whether it's a Netflix documentary or if it's the news that you turn on, or even if you're listening to podcasts or even reels that people are getting their information from. There's a lot of fear that has been born out of what's gone on, and there's a lot of uncertainty. People don't know that it may not be better options for them at the upper end of pain. And so they tend to be very nervous about the utilization, even when it's a necessary. And what we've seen out of this is it really is an inhibitory factor, whether that is treating their pain or getting them more functional so that they can sleep and heal better, or even things like making them functional enough so that they can actually do the physical therapy post-procedure that they need to do. So it's really a kind of a conundrum that bears itself out as, what are our options going forward? How are we going to deal with this? And this is some of the things that we started to contemplate in this paper.
It's a lot, to say the least. So I appreciate you guys, highlighting these there. So.
And I think that the paper is focused on a lot of the things that Jim was talking about, the medical side, but it's worth mentioning that there's a massive economic cost to all of this as well. When we started, and to just as a teaser, the paper focuses mainly on the medical. We actually have started looking into the economics and are probably going to be coming out with a sequel that's more economically focused. But as a teaser, when we started looking at all the related healthcare costs and loss of productivity costs related to addiction and related to undertreating pain, it's pushing $1 trillion. And then when you start looking at all of the societal costs, the law enforcement and crime and everything that goes along with addiction, it's probably over $1 trillion. And I mean, trillion. Normally, to get a dollar amount that's got that many zeros, you got to be talking about an AI company or something. So massive economic impact as well. And so we think that all this points to really an urgent need for the development of safer, less addictive therapies that can, treat pain at the level of opioids, but with, very different risks. And so I think that the opioid not going away, and the opioid problems are really inherent in their use.
Absolutely. And, I appreciate the teaser, of course, but, the big picture here of what you and all authors in the article, and just in general conversationally, really, of, looking at provider, patient, society, economic impact, policy impact, it's just a lot. But to only discuss or cover one aspect is just such a shortcoming. So I appreciate that going over all aspects. That's incredibly important. I'm sure both of you agree. So now, perhaps we could even, jumping into a portion of that here, maybe we dive a bit deeper into this balancing act that I think came up a couple minutes ago. I worded the whole opioid-phobia, danger, everybody, danger, good golly, versus the opioid-philia, perhaps of the past, utilization across the board, universally, not just acute severe pain when we're talking opioids. There's risks, of course, dare we say informed consent needed within, clinical practices and interactions. All medications come with their baggage. Good golly, if I had a nickel, we still make nickels, right? Yeah. If I had a nickel for every time I said that, but there's truth in that, of course. There's a lot of adverse drug events, side effects, whatever we want to call them. When it comes to prescription opioids, we have things like, and I usually hesitate to say minor because, the first one that typically comes to mind is constipation. It's like, well, that's not respiratory depression, so is it minor? Well, if you're the patient that's experiencing it, it might really matter that day or that month for that matter. So, constipation all the way up the scale to things like substance use disorder, addiction, even respiratory depression. There's a lot overall there. I don't know, James, if you wanted to add anything in that realm too, particularly with the background of everything you guys have done in the realm of prescription opioids, of course.
Yeah, thank you, Mark. I'd love to. I think that you're thinking about it the kind of the way we did. There's sort of, as a clinician, if you say, okay, I'm gonna, you've got Sophie's choice here, but I've got a patient in tremendous pain, so I'm gonna go ahead, I'm gonna give them the opioid. So I think, there's a long list of things that, in the industry, we kind of tend to brush over as like, no, manageable, things like, constipation you mentioned, things like, QT prolongation. These drugs can mess with your hormone levels, itching or pruritus, sedation. Patients go through, potential, range of things when you're treating them. The thing that I think really drew our interest more, though, than that even was, okay, what happens when you walk away? like, are there potentially, when the treatment's over, because then the focus here was more on the acute pain treatment, which should be self-limiting. What are the sort of secondary risks to giving an opioid to someone? And started looking at, what all the literature says about, the risks of things like dependence. We obviously talk a lot in the paper and think it's top of mind, the addiction problems, but people can develop, significant dependence to opioids by not doing anything wrong, by just taking them as their clinician is prescribing them and taking them for as long as is needed for their pain. They can become dependent. In fact, it happens in, probably more than 10%. The research says somewhere sort of 11 to 13% of patients who are getting an initial opioid prescription are becoming dependent. And that's something you see, even with short-term use. That can happen as fast as a week. And as I think a lot of your readers probably appreciate, opioid withdrawal is bad. You feel like you're dying when you're going through withdrawal, and it keeps a lot of people, using these drugs for much longer than they would otherwise, and sometimes, permanently. The other part, though, going down the other path here of what can happen is patients often feel euphoria with these drugs. They feel pain relief, good, but they also some of patients feel really good. In fact, one study showed that 25% of people who received opioids in an emergency department setting experienced euphoria, as one example. There were lots of studies on that. And it's clear that people that are misusing opioids are often driven by that feeling of euphoria, that they're feeling that on the first prescription, and then they're saying, well, if I wasn't in pain, this would be really fun. And sometimes seeking out more. And we're seeing, a lot of the misuse of prescription opioids are coming from that, that initial prescription. It's not like, somebody has to use for long. It's often, and there have been studies where they interviewed people that were in addiction, and often they would say, first dose, I knew that that was my drug. That was something that I wanted more of. And
yeah, James. So there's some really interesting anecdotes around this too. When people ask me, "Is this a real problem?" I listened to a really interesting podcast to an individual who was a professional who basically hurt his back in a sports league that they had for the company, and then went on to become an addict because of the pain medication that he had. And then subsequently became one of the most notorious bank robbers in the United States to support that habit. And I know we've all heard things like this, but I think for the lay public, it's interesting for them to actually have that type of exposure and have that material out there, because I think they tend to think that, well, it's more of a safety issue, and don't necessarily understand that dopaminergic component of it that is really important, and that which leads to that addiction a lot of the times.
Jim, for a moment there, I thought you were actually talking about me. Just the first part of the sentence, anyway. I had, and I think we've talked about this before, when I had an illustrious episode of nephrolithiasis, kidney stones, and the incredible pain associated. There was a acute outburst of the pain, and ended up utilizing what was prescribed for me at the time. It was a T3. Codeine with acetaminophen, mostly perceived as being, lower on the totem pole, but it's all about the dosage, baby. Anyways, in that acute situation, I had not eaten yet, but the pain needed to be taken care of. And on that empty stomach, I can tell you that the dopamine was flowing. And, but obviously the choice was not made to continue or, seek more and all that, a total different pathway. But my point in bringing this up is it's all of us and any of us that can have these experiences. So I really appreciate you bringing that up. And
I think that's great example. I think and I know there's been a lot of debate in the pain community over the last, years about, we hear about all the heroin and fentanyl addiction and the deaths, and how connected is that with the prescription of opioids? And that was one of the things we wanted to really investigate in the paper. And it's clear that there is a causal link in many, many cases. In fact, one study found that the majority of people addicted to these illicit drugs had that exact path, was exactly what we're talking about, that they were pain patients that got a prescription, felt high, and then made the wrong choice, which took them down a one path. And other research has shown that way more than half, maybe 80% of heroin users initially were misusing prescription opioids. And then the final sort of part of this on the sort of the consequences side of and how this is leading to addiction is it doesn't even seem possible to stop this as a clinician by picking the right patient or counseling the patient, because actually when we get into the misuse of these prescription opioids, most of it's not even happening with the patient that's prescribed them. Most of it is just the pills get out there and then they're stolen or otherwise diverted to someone else. And most of it's so most of the abuse or misuse, I guess is the preferred term now, is happening in someone that as a clinician you don't even see. And so to us, this is all pointing to, the need for a better option.
Absolutely. And it's just more spokes. There's so many branches and spokes within this overall major concern. Kind of pivoting a little bit, but what we already brought up earlier, of course, is, well, what about not treating pain? That's quite frankly harmful as well. Particularly considering, we mentioned earlier, I think it was James mentioned, going obviously from acute to even subacute and then chronic pain along the way, hopefully not picking up any central sensitization either. That's things amplify pretty quick. Any thoughts there?
That's actually a real challenge. And as I started saying earlier, I think depending on where you sit in your comfort for utilization of different product, it's either a positive or a negative. And I think, the avoidance of opioid due to concern, which I think everybody is aware of, is very prevalent. And it's just one of those things that you have to be careful about. And if you just take a painful procedure as an example, you have shoulder surgery, you have a knee surgery, something of that nature, and you don't use it, well, then left uncontrolled, we know that we can go to, as you were saying, Mark, the end of chronification. That's an outcome I think that no one wants, but it's also not as predictable as anybody wants. But if you look at it from the other side, and I briefly touched on it before, and you take it from the patient's perspective, you have consequences that are more immediate. And so if you think about it from a patient's perspective, either reluctance or their unwillingness to prescribe them can lead to a lot of negative things. We had a surgery in the family very recently. They were very reluctant, a very educated person, to taking it. And after about 3 days of watching this, I basically just said, no, you have to take it. You are not sleeping at all. You are never going to heal. And that becomes a true issue. And as I said, this whole concept of making sure that you need to do what you're doing, hip surgeries, as we know today, you're up walking the same day. How much more reluctant are you going to be to do that or go to your physical therapy if you're in excessive pain? So it's really dependent on the types of pain that we're talking about, the intensity of pain that we're talking about. But that's really kind of the message, right? So when you look into things like severe post-surgical pain, we know that you can get yourself into the development of chronic pain. And the more intense and the longer the duration, the more opportunity it has to become centrally sensitized and have a longer term problem with it.
We basically need to have our cake and eat it too, right?
Yeah, that's exactly right.
Well, like any conversation in this Accord, we usually leave with more questions than answers. But what you guys alluded to, perhaps a second version of an article, or a follow-up, part 2. But even before that, was there anything that didn't make it into the article? Would you like to share here with our listeners?
I think the article, didn't make it into the article, I think, is probably, some of the, the research attempts to then solve this problem. I think, we're not far from the first people to recognize these issues and the need for better treatments. It's, pain drug development is hard. There have been, failure after failure of new mechanisms, people trying to develop things that in the lab or in animals looked great, and just for one reason or another didn't make it, didn't make it to approval. Whether you're talking about, the P38 inhibitors, the anti-NGF drugs, the TRPV1 drugs, there's been, mechanism after mechanism that have failed. I think the positive news is that there are at least a couple of mechanisms that seem to have gotten past that hurdle and are succeeding. I think the one that's probably top of mind for everyone is suzetrigine, which is the Vertex drug, sodium channel blocker, selective sodium channel blocker. And the selective is obviously very important, selective for the 1.8 pathway that was approved almost a year ago in the US, which blocks pain signaling in the periphery, or blocks one of the important pain signaling pathways in the periphery. And I think, has the potential to replace, some opioid use. A second one that's near and dear to our hearts, is the dual NOP-MOP agonists, or dual NMR drugs, which are full agonists at the mu receptor, just like oxycodone, pick your favorite opioid, but also full agonists at the NOP receptor, which turns out to really fundamentally change what you get from those drugs. You still get the opioid level analgesia, but with a very different safety profile, very different abuse profile, dependence profile, et cetera. And that's a mechanism that's not approved yet, but is through phase 3 and has shown clinically a very different profile. And so I think, there's hope on the horizon, we think.
That's literally what I was hearing, was the hope.
One thing I would like to, sorry to interrupt, one thing I would like to add to what James was saying, because I've actually worked on some of these in different organizations that I've been at, is the amount of effort that's gone in, and this is something I think that people, perhaps even clinicians, don't have a full appreciation for, is substantial. And so it is very difficult in today's world, as you may imagine, to try to get a pain product approved. And a lot of that is because of mechanism that may be attached or other types of things. But one of the big things that becomes a problem is recognize your comparator is, especially in the upper end of pain, when you're looking at higher intensities, is an opioid. And opioids on the therapeutic side, and I'm not talking about the things that we've talked about in terms of adverse effects and the negatives that we know about opioids. The downside when you're looking at development is the effect and the efficacy of those are actually very good. And so a lot of times it becomes quite hard to actually compare yourself to that. So when you find something like James was talking about with this dual NMR receptor product, then you have an opportunity to actually play in that same realm and make sure that you're looking at it from a perspective of, now we're actually looking at something that could be equal while actually minimizing some of the downsides.
It's an important point that you brought up there, Jim, because it's like MLB players, going up against MLB draft league players. Sooner or later, someone will get drafted and make it, but it's not going to be everybody. So I hope that brings some light to our listeners here too. All right, you two are probably thinking you're getting off easy here, but there's always one or two questions I ask every guest in the Pain Pod here. So here's my first one. And James, maybe you want to go first. How do you define pain?
That's a tough one. I think,
always.
Obviously you can go to the textbook answer, ISP or whoever defines, pain. But I think, and that's all right. But I think the important thing is not to define pain as a broad category. And actually, Jim and I were just talking about this, and he actually probably said it better, but I'll try to paraphrase, and he'll jump in and correct me. But, we think of pain, we think it's probably not even right to think of pain. It's more important to think of pain type and origin. and because that's going to get us to a better treatments. We used to think of cancer, right? People would say, oh, you've got cancer. And then it was like, well, now we have, then it became a type of cancer, well, carcinoma or melanoma or sarcoma, whatever. And now it's almost like every cancer is an individual disease because you're looking at the genetic footprint of that tumor and then attacking it exactly that way. And so I think it's probably to not to attempt to sidestep your question, but to kind of sidestep your question, we shouldn't be defining pain. We should be defining subtypes of pain in some cases.
So let me just add a couple of things to it. And
Sure.
James, I think you did very good encapsulating our discussion. The other bottom line is you actually have to look at the patient too. I mean, when we talk about pain, it's very important to talk about it in the context with the way it's being experienced. The type of pain that you're talking about, yes, very, very important. But we also don't need to treat a small issue with a big hammer. Or a big issue with a small hammer. I think it's really important to put it in context of what it is. And that's why it's so important to think about it from a perspective of what are we actually dealing with? And that whole analogy that James and I were talking about came about because I did my training in the oncology arena. And frankly, in the olden days, and I'm probably aging myself a bit, we did think about it in more simplistic terms. And that's been a substantial evolution, and I would love to see the same type of evolution come into pain medicine.
I got to give you guys credit. You were saying that you might be sidestepping, but you weren't. The almost entire reason I always ask pain pod guests this question is because it's something I ask patients as well. You tell me what you think it is, and your thoughts there were very patient centric, and that's incredibly important overall. Whether it's in talking with a patient to set up what the goals are actually going to be, or how somebody defines their own pain, it's going to be different. All credit to IASP. I know they spent a lot of time on that sentence/paragraph, but it's going to be different for everybody. So thank you, gents. All right. But the follow-up one, what is your favorite pain medication? And of course, why?
So let me take that one first because I'm going to completely dovetail it to what we just talked about.
Okay.
This is actually really important. And again, we all learn things formatively. For me, my favorite medication is the one that's most appropriate for the person. And that gets back to a little bit of what I just mentioned, right? And I think it's really important to put it in context of the person who's receiving it, the type of pain that they have, what's going to necessarily treat the pain. Is it going to be something that we're going to be looking at for a short duration? Is it something that's going to be end-of-life therapy? I think these are all really important components to say that there isn't a magic bullet. There's going to be things that we kind of talked about that are going to give us better tools. But ultimately, what it gets down to is make sure you're considering the patient, the issues that they are, where they're sitting at their time within the confines of the pain that they're having or the disease course that they're experiencing, and choose the appropriate option because that's going to be the one that's most impactful for them.
Thank you, sir.
And I would agree with everything that Jim said, but I'll give you an actual product that fits into that. I'll give you the product that really helped my grandmother the most, and because it's kind of a positive but frustrating anecdote. The product that she could take that really helped her was Voltaren gel. And I actually the diclofenac topical because she was able to take that because she doesn't get a lot of systemic circulation and can help where you apply it. And I actually I learned about this medication when I entered pharma, and I went to her and I said, I think this could help you. You got to talk to your doctor about it. She was, very happy. And it's like, I'm going to go talk to my doctor. Well, of course, living in a rural area, she talked to her doctor, and her doctor never heard of it. Okay, that didn't help. So that was a dead end. So I said, well, let me see. It was at that time, it was still prescription in the U.S., so you had to get it to a doctor. And so I picked up some, and outside of the U.S., it was over the counter. And so I picked up some for her once, brought it back to the U.S., gave it to her, is probably not fully legal, so I'm outing myself. Gave it to her, and it was tremendous. It really had this massive effect, on her pain, and was like a lifesaver for, while the tube lasted. And so for a few years, every time I took a trip outside the U.S., I would end up in a pharmacy to buy some of this. But of course, it can't be as simple as, well, just give me a case of that. It was, quote, over the counter, but you had to talk to the pharmacist and then, get them to get provided for you. And so you had to basically convince them that you needed it while you're on your trip outside your country. And so, I get 1 or 2 tubes from someone, bring it back. That was, she was great for a month or so and then out again. And so it was a nice thing when it was there, but it was a frustrating experience as well.
It's an incredible experience. That, considering that was approved, it was Valentine's Day, I want to say 2014, but about a decade ago, when it got approved for OTC in our country. I too saw it on shelves in gift shops and hotels outside of our country. Good golly. I think putting together what you guys were saying was, what's the favorite one? The one that works and is accessible. We could never forget about the access along the way as well, too. So, well, gentlemen, thank you both very much. Hopefully it was a joyride for you here. Always got to enjoy the adventure. But as far as our Pain Pod listeners, I hope this was more than worth your time and really spurred some thoughts to think about those spokes, the branches of this overall opioid story that we have been living and will continue to live along the way as well, too. All right. So please do, join us for our next episode of the Pain Pod. Stay on the edge of your seats. We'll debut some new topics along the way. But in that realm, till the next time, Pain Pod Nation, thank you and have a great day every day.
If you'd like to join Mark on the Pain Pod, send us an email to publisher at pharmacypodcast.com. And make sure to share the show and subscribe on your favorite podcast directory. Thanks for listening.